And so here are my conflicts of interest to disclose. I don't think they'll affect my ability for us together to achieve these learning objectives. Hope to assemble the skills necessary to accurately assess the QT interval and see if you and I agree with what the computer said. To examine 6 pearls that I hope will help you avoid some serious QT miscues, and then identify what are the cutoff values that warrant further investigation. And then I'll come back in a little bit to talk about what should that diagnostic evaluation look like. Are you impressed with this ECG? So this is where it's like uber long. And so this makes the diagnostic evaluation pretty straightforward and easy, perhaps, and I'll come back to this. You might immediately say, oh, that's that long QT syndrome, the genetic channelopathy that affects 1 in 2,000 people, but an important point is that just because you show a prolonged QT interval doesn't mean you have congenital long QT syndrome. And in fact, in all of medicine across all of ages, most of the time, you don't have long QT syndrome when you evidence QT prolongation. Instead, you might have acquired QT prolongation secondary to a variety of QT aggravating medications for which the issue of drug-induced torsades and drug-induced sudden death is actually much larger of an issue than congenital long QT related deaths, where these deaths happen because of wrong drug given at the wrong dose to the wrong patient at the wrong time. So if you don't know about this list of QT aggravating medications, you need to know it and have it available. It's crediblemeds.org. And then we have on the flip side this issue. So 1 was really long. Now look at this electrocardiogram. If you agree with what the computer said, then I need you to tell me, is this ECG diagnosis normal or abnormal? It's easy, isn't it? After that great salad that we had, this is as normal of an ECG as it gets. Unfortunately, this completely normal ECG happens to belong to somebody who absolutely has long QT syndrome. And it happens to be a family member, which the point I'm trying to make here is that in the context of having diagnosed a family with long QT syndrome, we must not tell them your ECG is normal, therefore you don't have the family disease. In that context of a family evaluation, only a negative genetic test can rule out the presence of the familial disorder. So when that's the setup, we should never tell somebody your ECG is normal. There's no ECG that's too normal when you already have a 50-50 chance of having inherited the disease. Well, then when we look at the QTC and we have this issue, let's look at this electrocardiogram. You see what the computer said. You will know how to confirm the computer. In this case, I'll tell you the computer got it right. So, and the computer thought it's normal. Is this ECG normal? Well, despite a normal length of repolarization, there's nothing normal about the look of repolarization as I'm evidencing here. And so this is as much as we'll focus on how to measure the QT interval correctly, there is the skill and the seasoning of the look of repolarization. And one of my favorite colleagues, Peter Schwartz, said once, I don't measure the QT interval, I look at it. And getting used to the pathologic looks of abnormal repolarization that do have a genotype suggestive pattern, sort of the look of broad-based T waves where those T waves don't look right, the look of notch T waves, particularly when that look is in the lateral or apical precordial leads. And then the look of a normal T wave inscribed after a prolonged isoelectric segment. So there's different looks of repolarization that make us more or less suspicious that pathologic repolarization is going on. So let's work to see if we can get it just right. So here, and why do you and I need to get it just right? Well, because the computer sometimes doesn't. So this is from Mayo Clinic, not a bad place. Our ECG reading room, where this ECG came out as this and not corrected in the over-reading process. So I love to use this ECG as a way to remind us that the computer QTC is accurate plus minus 400 milliseconds. Okay, so you and I, if we're going to order the ECG, we must not rely on the computer's QTC. Now, having said that, it turns out that the computer gets the QTC right better than we do. So that is the challenge we have. A good friend of mine 12 years ago, Sammy Viskin, said, we're not so hot at doing this thing called measuring the QT interval. And it's actually quite easy, and I'll make you superior to the 3/4 of cardiologists and the 1/3 of heart rhythm specialists who don't get it right. Now here's why we need to get it right. This is from an early on in our program of nearly 200 consecutive patients who are all told by pediatric or adult heart rhythm specialists that you have long QT syndrome. And when they came for their second opinion evaluation, we agreed in a quarter, we said possibly in a third, but 40% of the patients who came to Mayo Clinic 10 years ago and still now are being dismissed from Mayo Clinic without the diagnosis of long QT syndrome. Most of those reversals are reversed back to called you are actually normal. So there's a tremendous overdiagnosis of long QT syndrome going on out in the general community. And the number one reason for overdiagnosed long QT syndrome is summarized here. The QT error, where this QTC that is called really normal got made really abnormal when somebody looked at V2 and V3 and then bit on the U wave there, see that? And then said, that's not 410, that's grotesquely prolonged at 535. So, and then got implanted defibrillator for their dangerous long QT syndrome, for not only did we reverse it back to 410, but we then removed the ICD. So we need to go back to basics if we're going to confirm the computer's QTC and do what has been called the teach the tangent or avoid the tail, so we don't do the sin of QT inflation due to U-wave inclusion. And we draw the isoelectric segment, we go down the downslope, and we intersect the end there, and we resist the urge of taking it way out there, which will grossly overestimate the QTC. And when we do that, and if we combine it with these 5 pearls, I think we can get really, really QT good at saying, did the computer do it right? And we'll be better than them. And so here are the 5 nuggets, if you will. First, when you do your independent confirmation, lead 2 and lead V5 are your friends. Stay away from V2 and V3. Don't even look there for the length of repolarization. You can look there for a little bit, but lead 2 and V5 are your friend right now. And then you go down V5 and you put your eye or your caliper at the beginning and the end of the T wave. It's really quite easy. And then you ask yourself, am I getting the same QT interval that the computer got? And if the answer is yes, you've confirmed the QTC, because the computer is really good at something called mathematics. So it can do the square root of the RR interval, and it almost always gets the RR interval exactly right, better than we can in terms of the average. So if you're getting the same QT as the computer is, you've done it. You can on the fly eyeball things and say if your QT is less than half of the preceding RR, then you know the calculus will be less than 460. That doesn't mean they don't have long QT syndrome, it just means that their QTC is less than 460, which almost always means they don't have long QT syndrome. So that's how you can do it really fast as the eyeball fly. Are you under or over 460? Be really careful in the setting of sinus arrhythmia and atrial fibrillation that you resist the urge of saying, well, where's the longest QT and where's the shortest RR, and I'll just use that for my math. That will grossly inflate the truth. And you will overdiagnose long QT a lot. Take the average. The other thing you have going for you is if there's atrial fibrillation or a lot of sinus arrhythmia present, they don't have congenital long QT syndrome, because those two entities almost never coexist. So you're mostly doing this for the purpose of adult medicine because you're about to add a QT prolonging drug to their therapy and you need some sort of baseline as to whether that person is going to be having a QT reaction to the drug or not. And then remember that the patient's QTC reality starts to break down at slow and fast heart rates. It starts getting underestimated in bradycardia, which is where a lot of our athletes are, and overestimated at high heart rates. But one of the things I observe a lot happening is their heart rate is 45. Don't call the QT interval in that context the QTC, because that will swing it in the opposite direction and then quickly overestimate things. So just recognize that the computer-derived QTC, which you even confirm, is probably less than what their QTC truth is had they been in a heart rate zone of, say, 60 to 80 beats per minute. And then here's a bonus of what if there's a wide QRS. First, the beauty is if there's a wide QRS, they don't have long QT syndrome. So those almost never coexist. This is, again, for our adult colleagues where the person with a wide QRS is going to be put on a QT drug or has a QT disease process going on, and you want to see is the drug, is the electrolytes, is the disease aggravating the QT system. So forget about JT curves and JT norms. We barely know QT norms. Just do an adjustment for as if the QRS complex was normal, as if depolarization was normal, and then follow suit there. So you know now how to confirm the QTC. You know these nuggets to make sure you confirm it right. What QTC value should bother you? Now, if we were to do a survey, we would end up with a beautiful Gaussian distribution of where you would say we should act on it. And that's a real problem. If we can't even decide as a community of cardiologists or sports medicine which QTC should trigger or compel a follow-up reaction, we need to work on that because we have not understood or taught about this metric of repolarization where the QTC is our best metric of cellular cardiac repolarization. In health on the left, disease on the right, men and women are different. You have to know what is the average QTC in health and disease, what's the average QTC in congenital long QT syndrome, and what's the spread to decide where you want to set your cut points in terms of specificity and sensitivity. So yeah, this is highly specific, but completely impractical and irrelevant because you'll discover one patient with long QT syndrome. So we need to move the threshold from these high risk lines, and 600 is one, 550 is one, probably a line in the sand that you should never forget, and no matter what your practice is 500 milliseconds. Except for two reasons, wide bundle branch, wide QRS, and the presence of amiodarone. Anytime any patient in front of you has crossed 500 milliseconds, they've entered into torsadogenic territory. That doesn't mean death is tomorrow, but it means they've entered into a proarrhythmic risk window of life, and you need to account for why they're over 500, and you need to try to get them under 500 as best you can. From a diagnostic standpoint, we have this problem, right? I showed you that ECG. QTC perfect, 415, but she has long QT type 1. This is that subpopulation, which isn't so small, of normal QT interval long QT syndrome, for which about 40% of all long QT people live there. But that's okay because most of those who live there are the asymptomatic family members. That's not who we're needing to catch with a screening program. We need to catch those who might do events rather than those who just need to avoid Zithromax. And we'll find all of the rest of these later in a follow-up evaluation because you can be really normal. Here's somebody in our program who has long QT, no doubt about it, and yet her QTC is at the best first percentile of cardiac repolarization. And then 450, how about let's use that as the screening line. You saw Dr. Dresner said that's what the Europeans do. That's really, really bad. because they should be calling 20% of all Europeans as having long QT syndrome, or at least borderline QT prolongation. And now we have to remove that borderline designation to 450 for women and 460 for men, 450 for men and 460 for women as the lines in the sand for an ECG definition of prolonged QTC. But even if that satisfies a guideline definition of prolonged QTC, that doesn't equal long QT syndrome in an asymptomatic host. Well, it actually does, just less than 1% of the time. So just because you satisfy a guideline definition that's been put out there doesn't mean that this is the good thresholds or cutoffs to establish a screening program. What are they? Here they are. We have said this for years. The international guidelines now support it. 480 in women, yellow flag. 470 in men, and 460 before armpit hair. These are the thresholds that you should raise a caution note where you should say, I should look at this, I should think about this. They don't equal long QT syndrome, but they equal about a 10% positive predictive value for having uncovered a 1 in 2,000 disorder. That's not bad as a place to pause on it. But don't force a diagnosis just because they've crossed these lines. Compel a workup, and I'll show you later what the workup is. But again, if you want one line to never forget, 500 milliseconds. If they are asymptomatic healthy, you have now found long QT syndrome more likely than not. But in medicine, don't think that the 500 line is that rare when they come to our practices as unwell people. This is a summary of the QTC values at Mayo Clinic, and you can see the distribution and see how it skews to the right. That's because we see a lot of people at Mayo who are called I am sick. And anything that makes you sick, almost anything that makes you sick, starts pushing your QTC to the right. And these numbers, you see how many they have? Well, you have to know what the y-axis is. I love this. This is how many ECGs we're talking about. This is the QTC distribution among over 2 million ECGs. Now, if we use 500 here, we don't have 30,000 people at Mayo Clinic with long QT syndrome. This is called what I do when I start to get ill from cancer, when I get ill from a subarachnoid hemorrhage, when I get ill from coronary artery disease, diabetes, and so forth. And that's why the QTC of a healthy athlete, their QTC distribution is going to be shifted to the left because they're called I'm healthy. Once you start to get diseased, your normal distribution moves rightward by about 10 to 20 milliseconds. We have felt that the 500 line is so important that we have set up an institutional QT alert system where no matter whether you are a psychiatrist or an electrophysiologist who ordered the electrocardiogram, if your patient has a QTC at 500, you are alerted so that we decrease the QT gap of those who are QT clueless with those who are QT aficionados. And we make everybody aware that that person might be at increased risk of a QT-related arrhythmia, or it may just represent somebody who is not a healthy host. And we actually see a 500 in 1% of all of our ECGs. So you would never see a QTC of 500 in any of Dr. Sanjay's athletes. So you shift over once you get disease. So in that setting, in a tertiary medical center, what do you think is the mortality, the one-year mortality of I'm over 500 and I do not have congenital long QT syndrome? It's actually 20%. A QTC of above 500 is a marker of an unwell host for which some of that we are accelerating their demise by not correcting their hypokalemia, by not removing the 5 drugs that they're taking for which 4 of the 5 are on the QT hit list and so forth. So I think we can do a lot outside the athlete issue, but hopefully I've convinced you to do not disrespect the 500 millisecond line. So how do we put it all together to sum up then, to make us get it just right? So here's this case from our own institution 9 years ago. She's 16 years old. Here's the QTC. Do you agree with that? The conclusion from the brain was prominent from the brain called the ECG brain. Here's her QTC truth, 560. It got the length of repolarization wrong, and it got the look of repolarization wrong, because that's not a prominent U wave, is it? That's a pathologic T wave. Those are pathologic notch T waves out there in V4. If you can't see that, that's what I'm talking about. That's not a U wave. And so it's a reminder that we always have to come back to that this is the ECG, not the report. So if we're ever going to order an ECG for screening, for sudden death predisposing conditions, or because the story drove us to get an ECG, we have to adjudicate the computer's QTC. Otherwise, you'll be vulnerable if you did not. And here was the consequence in our institution of this abysmal failure. Because it could have been different. Look, had they done what we talked about in our last 15 minutes, eyeballed the QT, put it in your eye or your calculator, and then said, wait a second, I'm getting 500. What's going on here? Why is the computer getting 400? Then you would have paused and said, we've got a U-wave inclusion-exclusion problem, and that's not a U-wave to exclude, that's a bad T-wave to include. Then we would have avoided this 4 months later. She died. Well, thankfully, just almost. She was resuscitated by her mother after 30 minutes of CPR and then rapid defibrillation, and she's thriving and doing well. But none of this story needed to have happened had anybody just done a little bit of QT respect. Here's one other thing for QT respect that's necessary. See that? Would we all agree leaving here today that the QTC of 626 deserves the penalty box? The flag being thrown? Now, we should confirm whether the computer got it right, and no, the computer's wrong, but it's still 514, and now we'll never disrespect the 500 line. She should have been evaluated further. Tragically, she wasn't, and 6 months later, her daughter died at age 19 from a sentinel drowning. Now, this evaluation for the mother was done not in a family medicine office or a psychiatrist's office. This was done in the office of her cardiologist during her evaluation and follow-up for hypertension. So the need to respect the QT issue isn't just in somebody else's neighborhood. It's right in our own specialty called cardiologists, where we still have a lot of work to do. So let me leave you with these take-home points. First, extreme QT prolongation does not equal long QT syndrome. Second, normal QTC values don't necessarily rule out long QT syndrome. Third, remember not only the length of repolarization, but the look of repolarization. Avoid the tails, exclude those U waves. Do not commit the sin of QTC inflation secondary to U wave inclusion. And then respect the 500 millisecond line. I would love to see you at our genetic heart disease course next year. And with that, I'll look forward to coming back up here in a little bit. Thanks a lot.